I'm Jules Hardy. For the archives of the American Association of Neurological Surgeons, I interviewed Dr. Claude Bertrand, a Canadian neurosurgeon, a Montrealer, in the generation of his classmates like Dr. Sweet, Eben Alexander, Blaine Nash-Old, Archer Ward, Bill Feindel. Dr. Bertrand became internationally renowned as a pioneer for his contribution in stereotaxic surgery for movement disorder and the treatment of Parkinson's disease. More specifically, he devised a special stereotaxic instrument called the Universal Pneumotaxic Guide, which is being used in approximately 40 centers in the United States and around the world. He had devised a special method of localization for stimulation of the thalamus and recording with microelectrodes. And he devised a method of doing the lesion with a wire leucotome. His experience throughout his career reaches above 2,000 cases. And more recently, he became interested in developing a new method for the treatment of spasmodic torticollis. Before we go into the details of those interesting surgical aspects, I would like to ask Dr. Bertrand to review stepwise his career. And first, Dr. Bertrand, could you remind about your background, family background, and education?
I was born in Sherbrooke, where my dad and my brother were both general surgeons, and I used to go occasionally to the hospital with my dad, and frequently when he was operating I would faint, so I decided that surgery was probably not for me. And I liked mathematics a lot, so I thought I'd go into engineering. And in playing sports, I'd learned some English, and I thought I'd go to McGill, and I started pre-engineering at McGill. However, during the year, they asked me to do a pre-engineering year because they thought that I needed more mathematics. Our schooling in French wasn't that strong in the basic sciences, and they thought I'd need more English. During that year, I had to tackle Chaucer in English too, and Chaucer was to me, and it still is, neither French, neither English nor Latin. So I was a bit discouraged about my success in learning Chaucer, Canterbury Tales. So during the year, I was hesitating a bit. I went back to Sherbrooke, and my brother convinced me that I should shift into medicine. At the last 3 months of the year, I went from pre-engineering at McGill to University of Montreal in pre-med, which was in French. And so that's how I shifted from engineering to medicine.
The whole education at that time was only in French at the University of Montreal.
That's right.
But you had further education at the McGill University in English.
Well, I had some pre-med.
Some pre-med.
Yeah. Actually, my next contact with English was later on in my career when I went for a year in general surgery in the U.S.
Do you recall any professor of anatomy, physiology during your medical education that may have influenced your future career?
Yes, I think two of them. Wilbrod Bonnet, who was the professor of histology, yes, and had us make some drawings of the nervous pathways and the connections of the nervous system. And I suppose because of this and an analogy with engineering, that stimulated me towards a further study into the nervous system. And then later on my studies, I had Pierre Matson, who was world-renowned.
The famous histologist.
Famous pathologist.
The trichrome collar of
That's
Matson.
right, that's right. And his work on the glomus and the nervous system. And so I was really stimulated towards the nervous system. At that time, neurology was more of a contemplative science. There was very little you could do either for epilepsy or multiple sclerosis or the other nervous diseases. So I was thinking, possibly because of my family connections too, about neurosurgery. And I didn't faint anymore when I'd go into the hospital, so I thought I could go into neurosurgery, and I went to see Dr. Penfield.
I understand your father was a surgeon.
Yes.
Do you think that his father image has helped you in selecting surgery?
It probably did. Also, I was quite pragmatic, and I felt that in surgery you could obtain definite results, although neurosurgery at the time was not too comforting. There was a lot of complications.
So did you thought first of becoming a neurosurgeon, a surgeon of the nervous system to begin with, so that you would go to medicine and surgery, or you just got through the regular pathway, becoming a medical doctor, then a surgeon, and afterwards you selected neurosurgery? What is the pattern?
No, I was always determined to become a neurosurgeon.
Yes.
In my latter years in medicine, and in fact I went to see Dr. Penfield to see whether I could come back to the neuro. And he mentioned to me, well, one thing that would be nice would be for you to get a Rhodes Scholarship, so you could come here and then go to Oxford later on. And so I applied for a Rhodes Scholarship and got a Rhodes Scholarship.
So we're about in the year of what,
1940.
1940, just at the beginning of the war.
Exactly.
During this period of time, you did your education training in neurosurgery in Montreal.
Before that, I went to Philadelphia, in fact to Bryn Mawr, right near Philadelphia, for my general surgery. And I used to go to the University of Pennsylvania for lectures in neurology, which was very nice because Friday night I had the concert from Eugene Ormandy, who was then the director, and the other director was not Sostakovich, but another famous director.
Who were the neurosurgeon at that time in Philadelphia?
Francis Grant.
Francis Grant.
Francis Grant, whom I met later, and I saw occasionally, and also another neurosurgeon whose name escapes me, which would come to Bryn Mawr, and I did my first surgery of the posterior fossa with him as an assistant while in general surgery, and I really took care of that patient.
Then you came back to Montreal and had your neurosurgical education under the guidance of Dr. Penfield at the Montreal Neurological Institute. For that was 4 or 5 years at that time, training?
Yes, training was 6 years, but I came back to Montreal, and then the war was on, and I joined the army because I wasn't married. So I started in the Neuro, and in 1942 I got married, and soon afterwards I was called by the army in 1943 to go into the army because they felt I had enough training to be useful in the army.
Have you done neurosurgical practice in the army?
Yes,
as
I did.
a soldier?
Yes, as a captain in the medical corps, I did mostly peripheral neurosurgery and back surgery, especially taking care of paraplegics.
As a Rhodes Scholar, then you went to England.
Well, I got my Rhodes Scholarship in 1940, but because of the war, I couldn't go to England. I was posted to go to Basingstoke twice, but then they started bringing the wounded directly to St. Anne's, so I didn't go to England during the war, but only afterwards, although I was posted to go twice.
At that time at the Neuro, it's called Montreal Neuro, Dr. Penfield had associates still at that time with him?
Yes.
Who were they?
Willie Cohn, Dr. Cohn, and Arthur Elvidge. And Dr. Penfield was the organizer, and Dr. Cohn did most of the practical surgery.
Well, at that time, Dr. Penfield, was he doing general surgery? Was he already doing only selective surgery for epilepsy? And Dr. Cohn was not doing epilepsy, but the remaining neurosurgical practice?
That's right. Dr. Penfield did mostly epilepsy. He did an occasional tumor or other things, but mostly epilepsy.
Yes.
And Dr. Cohn did the trauma with Elvidge. And Dr. Penfield was often called like going to Russia or elsewhere. And so I remember sometimes we'd operate at night with Cohn and at daytime with Penfield. There were only 4 of us then. And we had 1 night off every week and 1 weekend off every 6 weeks. So
as much as we're today?
It's quite different from today.
Tell us, at that time while you were training in general surgery, neurosurgery, you already started to become interested in epilepsy?
Yes.
Did you do some special research
yes,
or a thesis or
yes.
work on epilepsy?
I went into the army, and in 1943, Dr. Cohn gave me a letter, and I did a very interesting trip because I had 30 to 40 days for getting posted in the army, and I went to see all the well-known neurosurgeons at the time. I saw Walter Dandy do aneurysms without arteriography. I saw Byron Stookey in New York. I saw Glenn Spurling do disc surgery, and I saw also Adson at the Mayo Clinic, and Max Pete in Ann Arbor.
You did some work on the parietal lobe?
Yes. When I came back in 1945, I restudied some of Dr. Penfield's case because they had been reported by Joe Evans that the sensation involved the whole parietal lobe. And that didn't seem possible. It seemed that it would be the postcentral cortex. And actually, we found that it was only the postcentral cortex, and when surgery involved the rest of the parietal lobe, it was due to vascular ischemia or other reasons. But while doing that with Bob Malmo, we found that the minor hemisphere was the one that contained the body image, because he noticed when we were having these patients draw a human figure, the left side was neglected, or even drawing houses. And that was the beginning of our suspicion that the minor hemisphere was mostly connected with visual things and with non-verbal connections. And at that time, Dr. Penfield didn't believe us. It was only when Ehni came a few years after the war.
Ehni was the French neurologist.
That's right. That did work in Paris on that. And
the
he
one,
came to the Neuro.
and Alain Jouanine, the
Yes,
famous neurologist.
That's right.
On,
and Ehni came to the Neuro after the war, and he reviewed our work, and it was published, Ehni, Penfield, Bertrand, and Malmo. But it was work that was done in 1945.
Going back to your study when you went to England, you had a classmate, a famous anatomist who became a friend with you. Who was he?
Alf Brodal.
Yes. Will you tell us about Brodal a bit?
When I went to Oxford in 1946, right after the war, I was doing work in neuroanatomy on diffusion within the brain, and Alf Brodal had a cubicle near mine, and he was translating his work on the relationship of neuroanatomy to neurological disease, which became very famous. He didn't have much English, so I helped him with the translation. And I learned more from Alf Brodal than anybody I've ever met since. He was an encyclopedic mind. He knew his neurology as well as any neurologist, and his notions of neuroanatomy. Of course, his writings have been well known afterwards. But
did you help to raise a European Society of Neurosurgeons at that time?
That came later. In 1949, I went back for the first international meeting of neurosurgeons. And the French and the English wanted to form a European Neurosurgical Society. And Northfield from London and David from Paris asked me to translate from one language to the other. All the Saxons would speak English, like the Germans and the Swiss, and the Latins would speak French, like the Spanish and so on. And at one point, I thought I was creating a malaise because Northfield wanted to create committees, and David wanted to get the thing over with. And it became very embarrassing, and I refused to keep on translating. And I could see what happened at the United Nations. It took 10 more years before the society was formed.
Dr. Bertrand, let's keep forward now, coming back to Montreal. I understand that the very first generation of the founders of neurosurgery in Canada were Penfield, Botterill, in Toronto, and Turnbull in Vancouver,
and Mackenzie.
And Mackenzie.
Yeah.
Then you were of the second generation.
That's right.
And you were the first to found another service of neurosurgery in Montreal beside the Montreal Neurological Institute. Would you tell us about the first months and years that you founded this service at the University of Montreal?
When I came back, I was in the Department of Neurology. And I had to make rounds in neurology. And of course, I had a lot of trauma. There was a lot of accidents in the east part of the city, and I was the only hospital there, and there was no Maisonneuve or other places. So I came back, and I could see that I couldn't carry on being in the Department of Neurology, so I went to see the chief of surgery and asked to be in the Department of Surgery. And he said, I don't know anything about neurosurgery, so almost at once, I had my own department, independent of both surgery and neurology, which was easier to organize. And at that time, Jean-Louis Léger came back from studying in France and in Sweden, and we got very interested in arteriography, which Dr. Penfield didn't like because he was a bit allergic to arteriography. And we used to do arteriograms on head injuries to see whether there was a subdural or not, acute arteriograms. And that was the beginning of the wheel turning independently from the neuro.
And then you developed the Department of Neurological Surgery at the University of Montreal, Notre Dame Hospital. How soon did you become interested in stereotaxic surgery?
Well, at the beginning I was trying to do depth recordings for epileptics, putting little electrodes into the temporal lobes. And after a while I read the work of Riekert, and when I went back to Paris, I saw Fenelon do an ensotomy, and I thought that might be a good technique to
But the ensotomy was an open procedure, was it?
open procedure. He'd go through the temporal lobe and get to the ensa under the optic nerve, and that seemed a bit risky. So I did a couple of ensotomies under the frontal lobe, just above the optic tract, and then it seemed that this should be done stereotactically. Spiegel and Weisses had their apparatus, Lexell too.
Since when?
1947, 48.
So you were talking for your own
Oh, I started...
beginnings, 51, 52?
Yes, that's right. And at that time, you had to put the patient to sleep to put these big instruments on their head.
Big frame.
Big frames. And I thought for a case of Parkinson that was impractical. And that's when we started designing our own instrumentation for rapid fixation and using the central beam to know exactly what the magnification was, because we didn't have teleradiology then.
Do you have some pictures showing us about the development of this pneumotaxic guide?
Yes, maybe we could look at some of these slides. The first slide shows the original apparatus, which was rather rudimentary, as you can see. It was only fixation on the temporal and the occipital region, and then introducing a guide into a burr hole into the brain. That was rapid. That was 1954. In about 2 years, this was replaced by the more sophisticated instrument which you see now. And this instrument allowed us to correct for parallax. We use a lineated prism to line up the instrumentation outside the brain before putting it into the patient's brain, so that the final localization was simpler. Also, because of our experience in epilepsy, we thought that stimulation should be used to correct for individual variations, and we used a triple lead needle electrode, which you were very familiar with and use also yourself. And we could stimulate the motor fibers underneath the thalamus to know where we were exactly, and sometimes the sensory fibers if we were too far posterior. Then the instrumentation became more evolved, as we can see in the next projection, and it became a rather complicated instrument, but very simple to use, which was teleguided and could be so that the
That
patients...
one is remote control, outside of the operating room.
That's right. So we could move the patient's head to center the patient's head exactly as we wanted once he was into the instrumentation.
Regarding the patients, Dr. Bertrand, in the beginning, most of the cases for stereotaxic surgery were patients suffering from Parkinson's disease.
That's right.
Where was the first target in the brain that you were using?
The first target was VOA and VOP.
But you did some pallidotomies in the beginning?
Yes. Oh, yes. I forgot about the pallidotomy. Before we go to all the first lesions were pallidal lesions. They were quite effective, but the patient was sometimes drowsy, and you had to make a bigger lesion because that was the origin of the ensa lenticularis, so you had to take all of globus pallidus 1 to really get a good lesion.
So you move the lesion back to the thalamus.
Back to the thalamus.
That was in 54, 55, 9
oh,
of the
man,
years?
56, 57,
Yes.
after the work of Hassler.
You did introduce stimulation very early in the beginning of
Yes,
the
in
stereotaxic.
1955, 56, at the very beginning.
Would you tell us a little bit about physiological stimulation?
Yes. I think I will show a little strip of film
Yes.
which will show you the stimulation.
The lineated prism is attached to the graduated grid to avoid errors due to parallax. The guiding needle can then be lined up precisely outside the patient's head on the usual target point for tremor. These measurements are transferred to the triple lead needle electrode so that the second or intermediate lead will be at the lower margin of the target point and at the lower margin of the proposed lesion. Recordings are done as the electrode is being introduced. As it emerges through the thalamus, the fine mechanical trauma of the needle causes cessation of tremor, a critical proof of satisfactory placement. As we will see on the model, where the thalamus appears in green, this occurs as the electrode, having passed through VL in red and then through VP in blue, emerges into the subthalamus before reaching the motor fibers shown in yellow. At that endpoint, 2 per second stimulation causes clonic movements, more marked in the foot and leg in this case. During that time, the control X-rays have been developed. Monroe is now in line with the center of the screen. The guide shows the actual position of the second lead, which seems more posterior-inferior because of magnification. Air and radio-opaque oil outline both commissures. Before proceeding with the section, the hand is tested again for tremor, rigidity, and also for sluggishness of movement or bradykinesia. The patient is now trying to open and close his hand as rapidly as possible. The electrode has been replaced by the leucotome. The X-ray shows that the section will be centered at 14 millimeters from the midline and in the lateral view at 17-3 or 14 millimeters below the intercommissural line, that is 8 millimeters above the lowest lead, which gave rise to the motor responses. The actual section is now performed by very small quadrants of 5 to 10 degrees to avoid any possible tugging on blood vessels by the blunt wire. On the model, the extent of the lesion is shown in its maximal dimensions, with its lowest part 6 to 8 millimeters above motor fibers. By merely opening the wire, it can be used for temporary suppression of function in a given quadrant, since one is guided by the hypotonia and the clinical effect, as well as by the results of previous physiological studies. In contrast with concentric lesions, it allows the operator the unique advantage of varying the size of different quadrants. For instance, one may choose to omit part of a section of the antero-external quadrant in a major hemisphere if it should lie close to speech association fibers. No preoperative death, no hemiplegia, nor even hemiparesis have resulted from such lesions in some 700 consecutive cases. No transitory Babinski sign is evident. However, there is good relaxation and the movements are satisfactory. While the result obtained may not be perfect in many cases, it is rare indeed that a well-localized lesion does not produce unquestionable motor improvement.
As you can see in the next projection, that it became a stereotactic room, which has also been used since then for epilepsy and for pain surgery by Dr. Martinez, and for also stereotactic surgery. Dr. Hardy, when he came back from working with Guillot, brought back the microelectrode, which Ad Fessar was using with Guillot. Is that right, Dr. Hardy?
That's correct. That's in that operating room setup. that big tower that we see behind, what is all the electrophysiological
That's right.
apparatus.
Yeah.
And the big one on the right is the image intensifier.
Yeah. So we could see on TV where we were. Yeah. From then on, we decided to widen the field a bit, started using it also for essential tremor, for certain cases of pain, frontothalamic sections, and afterwards for choratitosis, but not so much as that as dystonias.
I recall that you had many patients beside Parkinson with essential tremor.
Yes, that's right.
This is a particular problem located with the people in Quebec due to family history of tremor?
Partly, but it's quite widespread. Here, there's more tremor in families that have dystonia, as has been about 20% of families that have torticollis or dystonia have tremor. And since we saw quite a few dystonias, we saw also essential tremor. In these patients, the lesion was placed in the thalamus at the level of VOA, VOP, and the critical part of the lesion was found to be immediately subthalamic. You can see that this lesion...
That's a sagittal
that's
view.
A parasagittal view, about 13 millimeters from the midline, and the lesion skirts just above the subthalamic nucleus. That's where the microelectrode is very important, because with the microelectrode you could find at what depth you would get into the subthalamic nucleus. So we never had any case of billismus because we never got into the subthalamic nucleus itself. And that was the lesion that we use for Parkinson's and for tremor.
Will you tell us about the method that you were using to make the lesion? There was a lot of controversy at the beginning between heating, freezing, what's called cryosurgery, thermocoagulation, but you had a unique method of doing the lesion. Will you describe this?
Yes, we were using a leucotome. It was a modification of Monet's leucotome. Monet's leucotome has a sharp blade and could cut through vessels. So we use a fine piano wire, which we got...
Which note?
A very high note, a very fine wire.
Very thin wire.
And the wire could come out of the rod, so you could direct the wire in any direction you wanted, and the wire can be turned only 5 to 10 degrees so as not to pull too much on surrounding vessels. And it allowed us to make radial lesions wherever we desired to make the lesion.
Beside Parkinson's disease, were you also interested in doing some patients with epilepsy, not focal epilepsy, but that would be amenable to stereotaxic surgery?
Yes, we did some epilepsia partialis continua, doing lesion in the corticospinal tract. We have 2 cases, because these are rare cases.
I recall Jacques Martel.
That's right. In fact, he's in the video that I showed you before.
Oh, yes?
And he had a very good result. A small, slight weakness, which he already had from his epilepsia partialis continua. And we tried also in the temporal lobe, and we had one good case in the amygdala, but that was not a large enough lesion to have a very good
Were there any cases of petit mal or grand mal with centromedium?
Yes, that's true. We did 12 cases doing a lesion in the centromedian. And these, about 33% of them were markedly improved, 33 moderately, and the other third, no real change. So we dropped it. We did about 12 cases.
And what about psychosurgery or pain surgery?
Yes, we did lesion of the frontothalamic tract above the dorsomedian nucleus, especially for obsessive compulsive. Something like what Tom Ballantyne does with the cingulate gyrus in Boston. And that was quite good. And in fact, in obsessive compulsives, I think that the technique should be reawakened.
Before we go into another chapter, you were also a general neurosurgeon.
Yes,
Not
I was.
only a stereotaxic surgeon. So you had a lot of experience in aneurysm, brain tumors, all kinds of other... At that time, there were many cases with abscess or infections.
Yes, we drained some abscesses stereotactically, too.
And do you remember Dr. Cohn in Montreal had a personal technique that we learned from you?
Oh, yes, yes. in people that had severe accidents with the forehead completely drawn in with a big rhinorrhea, or in fact CSF coming out through the wound. We used to remove all the fragments, pack it tightly, and I modified this technique by having the packing so I could pull it out through the nose rather than reopening the forehead. As the antibiotics became more powerful, that became unnecessary.
Do you recall so many other friends or colleagues, neurosurgeons, were visiting you? I recall Blaine Nashville, Archer Ward, and your friend Scoville. You have shared together some interest and founded a society?
We had the Neurosurgical Society of America in 1948 was first, we were the founding neurosurgeons, a little group, Arthur Morris, who used to be here, and Arthur Ward wasn't in that group. But in 1954, Claude and MacCarty from the Mayo Clinic formed the Neurosurgical Travel Club. There were 15 of us, never increased the number, and we meet every year. We still meet. Those who are left, there are 10 left out of the 15. But
that's a good score.
It's not a bad score. And so we still meet, but not in universities like we used to do, to see what progress was going. That became a very useful thing for us.
Were only all stereotaxic surgeons?
No. There was one from each big center. There was Lester Mount in New York, which was mostly aneurysms. Don Matson in Boston, who was pediatric neurosurgery. Claude MacCarty was general neurosurgery at the Mayo Clinic. There was Blaine Nashville. Blaine Nashville was in there was Bob Pudenz, and there was George Ehni. There was a very good group, Eben Alexander. But I imagine that some others have talked about it.
Well, it's very impressive that all these people that you're naming, they're all famous, they're all celebrities in neurosurgery.
Yes, well, I'm trying to find the chap from Nashville, Tennessee, Bill Meacham. Bill Meacham. Most of them became president of the ANS.
And of your generation, you had also in Europe, many of
yes,
your friends
Europe.
there.
Well, you went to Gérard Guillot, and I was early enough that when I went right to the war, I met Clovis Vincent.
You knew Clovis
I knew Clovis Vincent, and I knew André Thomas, and André Thomas was still doing his work on the cerebellum.
And in England, who were at that time, Hugh Cairns?
Hugh Cairns, when I was in Oxford, Hugh Cairns, and he was a good surgeon, but very, very deliberate. And once he was doing an operation, and it went on for hours. And he noticed that the clock had stopped on the wall, so he said to the anesthetist, he said, we have to get that clock repaired. And the anesthetist replied, why don't we just get a calendar?
That's a good one for neurosurgery. Dr. Bertrand, the next chapter you became most interested was the development of techniques in the treatment of torticollis or spasmodic torticollis. Would you tell us about the evolution of this technique?
That came from our interest in stereotactic surgery. I was doing surgery for dystonias and for torticollis, which is a local form of dystonia. And we'd have only two techniques then, rhizotomy, which was a shotgun operation, cutting all the nerve roots and limited downwards because of the phrenic nerve. You couldn't go below C4. And you cut both sides so that the neck was not very mobile and rather flaccid afterwards. Or thalamotomy. Thalamotomy gave sometimes excellent results, but in many cases it didn't give any result at all. And there was the risk of dysarthria because Hassler had suggested that the lesion should be at the VOI. This shows the convergence of all the dots right underneath the VOP into the innominate area, just in front of the motor fibers. And Francisco Velasco, if you recall, with you and Pedro Molina, went over 90 cases in which only introducing the microelectrode stopped the tremor.
On a few millimeter area.
2 millimeters wide by 2 millimeters anteroposterior. So it vindicated our contention that there was a optimal target. It wasn't only a question of volume, that your lesion should be directed at an optimal point, which is 8/10 behind the anterior commissure, just below the intercommissural line. And doing this sort of surgery, as I was saying, we had surgery for dystonias. But as we went on with our lesions further forward to get into VOI, as you can see, the fibers, for the motor fibers are the red ones in the back, but the ones in front are the corticobulbar, which are very close to VOI. And so once in a while, you would get a patient that would get dysarthria, which is a tremendous complication for anybody, even a
But
man.
was it only on the dominant hemisphere, or?
No, you could get it from the minor hemisphere, although much less frequently, maybe 3%, but in the major hemisphere, it could be as much as 8%, especially if you did the bilateral lesions.
Were patients totally aphasic or without
No.
speech, or slurred? Or
Slurred speech,
Slurred
but this
speech.
is a distressing
Distressing.
complication. So that's why
mainly in women.
well, yes, but even in some men like you and I. So I was started looking for something else, and when the result wasn't good, we thought maybe we can denervate the patients at the periphery. So I started blocking some of these patients with Novocaine and doing electromyograms, and finding that by blocking certain muscles, the ones involved, we could really stop the abnormal movements.
This is where you started to change the procedure?
They started to go to peripheral denervation. The
What
first-
year are we talking now?
77. I started in 75. In 77 in Brazil, I presented a combined lesions of both thalamotomy and peripheral denervation to avoid going into the major hemisphere, as you mentioned. And the results were very encouraging, but in the meantime, we started doing first the peripheral denervation, and then we decided why go ahead and do a thalamotomy. And so from 77 on, all the patients with torticollis only had peripheral denervations. Now there have been about 270 to 300 done in our department, and another almost 200 outside our department, like Carlos R.C. in Jacksonville, who's done probably close to 80 now, and Dudley Davis at the Mayo Clinic, and some in Germany.
What involves the peripheral denervation in terms of number of nerve to being cut?
Let's say in a typical rotational torticollis, the patient's head is turning to the right, let's say. You will denervate the left sternomastoid, but you have to denervate it completely, leaving the branch to the trapezius intact so there's no involvement of the shoulder. And then you go to the other side and do the rhizotomy. So
What is the evolution then actually with the torticollis of the last procedure that you've performed? The result is immediate?
the result is immediate, but you have to wait a few months to be sure the result will maintain, to be sure that part of the effect is not neuropraxia. And the technique demands quite a meticulous, it's done again with stimulation, with a light anesthesia. After electromyography, you identify the muscles involved, and at operation you stimulate to make sure that you get all the branches. If you leave any branch, there will still be movement. This slide shows an electromyogram and demonstrates very clearly that this patient's head turning to the left, the sternomastoid, which is the top tracing, and the left splenius, which is the bottom tracing, are very active even at rest. While in the next patient, it's the opposite. This patient's head is turning to the right. So the left sternomastoid, which is the big tracing on the third row, and is very active, in fact covering the right splenius, which is the tracing just above it, showing how selective the abnormal discharges are, and you can denervate only the muscles that are involved. And these are the results. It's effective in 88% of patients. In the last 50, 54% are totally, there's no abnormal movements left. In 34%, there are still some slight movements, but not enough to prevent the patient from leading a normal life. It has been, there are still residual movements in 12% of cases, and these may need further denervation. This will be shown now on a short slip of video, which will show two cases in which before we would have had done a thalamotomy, but now in which we can do only selective denervation. In this patient who had rotation of his head to the right for over 2 years and who was unable to maintain his head in the central position, denervation was limited to the left sternomastoid and the right posterior cervical group so that the patient could later on use the residual muscles to return his head to the midline. As can be seen in this post-op video, the head is now in the midline, and the patient can turn his head to the left as well as to the right without undue effort because he's had intensive physiotherapy postoperatively. He has now resumed his usual activities, this video being taken 4 months postoperatively, and the patient has also started in his usual sports such as golf, and he has no undue sequelae. Two following cases are patients with late onset dystonia who can also benefit from this procedure. In the first patient, the left sternomastoid and the right posterior cervical group are involved. The patient keeps his head forward because when he brings it back, he now suffers from clonic contractions which move his head constantly. This happens whenever he raises his head, as can be seen at present. These clonic contractions were quite severe, and to perform his duties as professor of physics, he had to lean his head against the wall to maintain some sort of stability. In this case, it was decided to proceed with selective denervation initially, and it has proven to be sufficient. In this post-op video, the patient can maintain his head immobile in the midline. He can turn it to the right and to the left with his residual musculature. He had good muscle tone and no difficulty in maintaining his head erect without any abnormal movements. These patients are up the next day, and physiotherapy is started 3 to 4 days after operation. He has now resumed his activities as a teacher and is functioning normally. In this young boy of 21, who had late onset dystonia for over 3 years, there was also marked scoliosis. In our own video, it is more evident that his head is maintained to the left by strong contractions, and that the posterior cervical group on the left as well as the left sternomastoid are involved. Luckily, in this case, the muscles of the left shoulder are not taken in, and the left shoulder is not raised as the head is pulled towards it. The advisability of performing a thalamotomy was seriously considered, but it was again decided to perform initially selective denervation. At operation, the left sternomastoid and the left posterior cervical group were completely denervated. As can be seen in this post-operative video 6 months later, this was sufficient. The position of the head is normal. He is back at school and he is playing basketball. He can now move his head normally, and the muscle tone is quite satisfactory. There is no appreciable limitation of the movements since this patient is young and has followed a very severe course of physiotherapy. In his case, the result was better than expected. Although results are not always as complete as in these patients, there are very satisfactory results in 88% of patients, and there have been no major complications or sequelae. It is therefore considered that this sort of procedure should be done whenever a patient have dystonias which involve mostly the neck muscle, because it is possible to suppress the movements and maintain good position of the head. The video of this 40-year-old patient operated on recently has been added to document what can be done for the difficult problem of retrocollis. He works in construction and first noted that his head was going backwards occasionally while nailing only 2 years ago. For the past 9 months, he's been unable to work, and he had to stoop forward because his head was fixed backwards by a severe tonic retrocollis, as evident on this video. Turn your head to the right. Okay, to the left. Backwards. Forward. Okay. Swivel, can you rotate? Yeah, like that. Good. Excellent. Okay, look straight ahead.
Dr. Bertrand, as you've been the program director for so many years, you must have trained at least 40 to 50 neurosurgeons from Canada, from the United States, from all over from Europe. Do you have any clue, and that's a major question for the future generation, how to select a candidate that you think would become a good neurosurgeon, as opposed to someone that you will refuse because you don't think he has a good background? Do you have any clue as a professor and teacher and chairman?
Well, the curriculum helps you, but it only tells you the ability to study the individual. The interview and the history of the resident is also useful. But it's hard to predict how good a surgeon you will be until you have it under observation for a while. And some of these may be very good technically, but not interested in the academic side. This you have an inkling before, according to what they did before, but it is only after some observation that you can really predict what the man will do.
We didn't mention too much about your personal life, but at least not only a surgeon, but you're a good sportsman. And what are you the best?
Well, I did a lot of skiing. I did a lot of powder skiing, tennis, golf, less golf than the others. And my last sport for the past 8-10 years has been windsurfing, which is much warmer than skiing.
Well, nobody knows except the people who train with you that you have a good sense of humor. So you'll try to find as a closure, as a special trait of your personality, I challenge you to find a conclusion and a joke. But I do remember one about you. When I was a junior neurosurgeon, I just graduated, had my Royal College fellowship. First week I practiced. We had a service meeting, and a case was presented of a lady who had intermittent headache. So as I just finished my education, I thought I was smart. I said, well, I think it's possibly a colloid cyst of the third ventricle. And I recall you said, Dr. Hardy, look, my young boy, the rare things are very rare and not frequent. So you may end up this interview with one of your well-known humoristic jokes.
Well,
in sport or science.
In science, I'm just thinking of the remark of Arthur Elvidge when there was a long meeting in pathology, and Dr. Penfield and Dr. Cohn had been arguing for about 30 minutes on whether it was an astrocytoma or an astroblastoma. And Arthur hadn't been consulted at all, and he was sitting patiently down there, and finally Dr. Penfield, the chief, said, Arthur, what do you think it is? Arthur says, well, I think it's a meningioma. On sports, what I was thinking is about 3 years ago, there was a beginning of a storm, and I told Claire I'm going to try doing some windsurfing. And she was very much against it. I said, well, if I'm in trouble, I'll raise my arms, you call the Coast Guard. So she was on the shore, and I was busy picking myself up, couldn't see my wife, and she was putting her arms up. And She was mad because I wasn't coming back. And this chap goes over and said, look at the old fool out there. And she said, you're perfectly right, he's my husband.
Well, on that very interesting interview, on behalf of the American Association of Neurosurgeons, I would like to thank you very much, Dr. Bertrand.
Well, thank you for the interview.